Hi, welcome everyone. Thank you so much for joining today's webinar on building a person-centered enrollment ecosystem for Medicare, Medicaid enrollees. My name is Lena Sharma. I use the she, her pronoun series. I'm the Deputy Director at the Center for Community Engagement in Health Innovation at Community Catalyst. Before we get started, I just want to take a moment and say thank you to Arnold Ventures for their support and their thought leadership in this project. And we'll move on to the next slide, please. Great. So just a few housekeeping details before we dive into the agenda. The slides and the recording for this webinar will be shared afterwards. Please submit any questions that you have using the Q&A feature. And for any technical support or difficulties during the webinar, please contact Mike Brand either in the chat on Zoom or through email at mbrand@communitycatalyst.org. Next slide, please. So for today's agenda, we want to provide a brief project background and some key findings. We'll share with you some policy pathways forward. You'll hear about findings from our listening sessions with enrollment assisters and beneficiaries, our recommendations, and then we'll have some time for discussion and questions at the end. Next slide, please. We have a great lineup of speakers for you today. We have Sienna Ruggieri, Community Engagement Consultant at Community Catalyst, Adam Finkelstein, Counsel at Manat, Phelps and Phillips, Brandy Bauer, Director of Health Coverage and Benefits at National Council on Aging. Next slide, please. So just a little bit about Community Catalyst. We're a national organization dedicated to building the power of people to create a health system rooted in race equity and health justice, and a society where health is a right for all. Together with partners, we're building a powerful, united movement with a shared vision of and a strategy for a health system accountable to all people. With this mission and vision in mind, we embarked on this project to better understand and improve enrollment ecosystem for Medicare, Medicaid enrollees. Next slide, please. So I'll now turn it over to our first speaker, Sienna. Sienna?
Hi, everyone. Thank you so much for being here. I'm going to kick us off sharing about some of the background that brought us to this report, as well as highlighting our key findings. Next slide, please. And then the following. Actually, if you can go back, sorry. Just some background on dually eligible people before we hop in. So what do we mean by dually eligible? Dually eligible beneficiaries are people who are enrolled in both Medicare and Medicaid who are eligible for a variety of reasons. This can be because of their age or their disability and low incomes. And it's really important to emphasize that dually eligible people are an incredibly diverse group. They are not a monolith. And this population spans from young adults to older adults. This includes people with physical disabilities, as well as people who have multiple chronic conditions. It also includes people who have dementia or developmental disabilities. Just a little over 12 million people are currently dually eligible. And just about half of that number are people of color, which is disproportionately higher than the Medicare-only population. And also more than half of dually eligible people have 3 or more chronic conditions, have a cognitive impairment or serious mental illness, and require assistance with their daily activities. And now we'll talk a little bit about what enrollment looks like for this group of folks. Next slide, please. Yeah, thank you. So the long and short of it is the existing enrollment environment for these folks leaves a lot to be desired. There's a variety of non-integrated and integrated options available, and navigating all these pieces is incredibly challenging. There's enrollment assistant exists, but there's a really limited number of assistants who are both trusted and knowledgeable on all the variety of options that frequently change. It's a really complex thing to track. Dually eligible people also deal with a really overwhelming amount of marketing. They receive a barrage of phone calls, mailers, official looking things they get in the mail, advertising all these different options to them. And it can be really tricky to discern what is marketing and what is something they need to respond to. All of these pieces make it really difficult to make an informed decision. It's a combination of too much and too little information. It's hard to discern from this vast array of information coming from all different angles, what to trust and what not to trust. So all of this makes it really hard for folks to feel empowered to make informed healthcare decisions. I'm going to throw the link in the chat to our last report that details some more of these findings. We talked with dually eligible people in 4 states and asked them what this experience is like, and that is reflected there. We can go to the next slide, please. So we know that the current model is not sufficiently person-centered. So what are we working towards? Based off of what we heard from dually eligible people previously, we know it needs to have at least these 3 things. This is not an exhaustive list, but this is an outline of where we'd like things to go and what we've heard is needed. So first of all, access to sufficient information, and this information needs to be understandable. It should be easy to read. It should be available in multiple languages. It should be really clear when you read that information what you, the individual enrollee, should do. You should have easy access to an expert who can walk you through all of your choices and in a non-biased manner. Just identify what's available to you and help you discern what's most important to you and therefore which health plan you should select. This should be available in a variety of formats, depending on what works best for you. So if you prefer in person, that should be readily available. If you'd rather use an online tool, that should be readily available. And really the big picture is enrollment policies, the materials that folks get in the mail, the benefit packages, and the provider networks should be reflective of and responsive to the needs and preferences of dually eligible people. A lot of times these things are decided for dually eligible people, not with dually eligible people, and it really shows. The folks we work with make it very clear they want to be able to make a true choice, and they can't do that without being able to influence these things. Next slide, please. All right, so this takes us to this most recent research, and we wanted to take what we learned in the previous report and use this research to give us insights into the feasibility of a resource hub. We felt this was a direct way to actualize the insights we gained from our previous research. So we were working towards these 2 policy objectives. First, building a permanent resource hub, as well as establishing a federal fully resourced program that trains and invests in those folks on the ground who are that trusted, knowledgeable source of information, making sure they have the resources and tools they need to serve all dually eligible people. Next slide, please. All right, so that's a bit of background as to how we got here. And now I'm going to transition to sharing more about what we learned. Next slide, please. Thank you. So based off our research, we define an enrollment hub as a 2-pronged resource. So one part of the resource hub is general and state specific information for beneficiaries and enrollment sisters, while the other piece focuses on training and resources for those who assist beneficiaries. On that note, these are other components to take into consideration as we work towards this research, this resource hub. This is a broad overview of what I'm going to share, and then we will break down what we mean by each of these key findings. You can go ahead to the next slide. Thank you so much. So like I said, these are some of the components we feel are really important in an enrollment hub. All of these are reflective of what we heard, both from enrollment assisters as well as dually eligible people themselves. So it's a real challenge of establishing depth as well as breadth. We want to make sure folks can easily access general information and making sure that general information is consistent. Currently, folks have a lot of different sources they're pulling from, and they don't always match up. So just ensuring consistency would be a real victory here. As well as making sure that an enrollment assister can find information specific to their state. We know the enrollment landscapes are wildly different depending on the state, so making sure they can easily access all those resources in one place. This also, like I discussed before, training resources, knowledge sharing, just a one-stop shop, knowing the overwhelming learning curve an enrollment assister has to face when they're looking at integrated options for dually eligible people. And something we heard a lot was the importance of contact information, both for beneficiaries themselves as well as enrollment assisters. A lot of times, these are very specific situations and they need to be tailored to an individual. And to answer those individual questions, usually it requires contacting some folks. So making sure that contact information is readily available so both beneficiaries and enrollment assisters aren't endeavoring on a wild goose chase trying to figure out who that might be. Next slide, please. So a big thing we learned was that SHIPs and other enrollment assisters play a huge critical role. And what they're especially talented at is providing a neutral and a welcoming enrollment environment. We think this can be bolstered and replicated. So what did we find with the current enrollment assistance environment? We found that enrollment assisters serve a variety of roles. They're not just enrollers, but they're also navigators, translators, educators, and advocates for beneficiaries making health plan enrollment decisions. Despite all of the resource challenges, both in terms of funding and capacity, they have an integral role. And they also empower beneficiaries with information, and they are the ones connecting beneficiaries to tools and information to advocate for themselves and make that truly informed decision that we're working towards. We also find enrollment assisters are a great antidote to this overwhelming amount of information that's out there. They can really help a beneficiary refine that information into what matters most to them, and that's going to depend on an individual beneficiary's preferences. I also find they're really critical in terms of just helping folks who are new to being enrolled in both Medicare and Medicaid. This is a really anxiety-inducing process, and having someone who can empathize and actively address those concerns, provide reassurance, provide just one-on-one support and acknowledgement that this is a really difficult process is critical to making folks feel confident and equipped with what they need to know. And a lot of times we heard from enrollment assisters that they are often the main advocates for beneficiaries. So when they encounter administrative issues or technical issues, it's often the enrollment assisters that are stepping in and filling that role. So we'll talk more about how we'll bolster and replicate this, but that's our top level finding for now. Next slide, please. So we talked about accessible and trustworthy information being few and far in between. And we found, particularly in terms of enrollment notices, there's still a lot of challenges there. So both beneficiaries and the experts we talked to cited enrollment notices not including information about language access or interpretation options. And if SHIP counseling resources were listed on there, folks had difficulty getting in contact with them. And we know how important it is for dually eligible people when they get that letter to be able to quickly reach someone, a person they can talk to one-on-one. And we found that most people prefer to speak with an actual person as opposed to using digital or written resources. So taking that preference into account is part of person-centered care. And we found that just the basics of Medicare and Medicaid, if we're in this world, so we might know a bit more, but if you've never been enrolled in one of these programs before, it's a huge learning curve. And enrollment assisters told us there's kind of limited information that's directly targeted to beneficiaries themselves about what is integrated care, how do these two programs interact with each other, which program covers what, just those basics. It's hard to find information that breaks that down in a really accessible way. And another thing we heard was dually eligible people need a really clear explanation of how the plan options available to them differ from one another. It's really in the status quo, it's really difficult to understand those differences. And if dually eligible people can't make a direct comparison, it's really difficult to make a decision and understand how the pros and cons of a particular choice. And this gets especially intense as the availability of integrated products widens. And there's often, as I mentioned before, a lack of a centralized source of information. So sometimes information contradicts another source of information, or it's out of date. So making sure there's a one-stop shop to look for this information and get an accurate answer. Next slide. So like I mentioned before, enrollment assisters have such a critical role, especially providing the one-on-one assistant that duals have told us loud and clear they would like. So due to this limited capacity, enrollment assisters are forced to really limit their time with beneficiaries. And often, every dually eligible person is unique. So being on really strict time limits is not ideal. And then you juxtapose this with how complex the integrated care enrollment environment is getting. This makes it difficult to be effective in the time that enrollment assisters do have. And we heard from enrollment assisters as a result, they're not able to do as much outreach as they would like to do. And of course, this impacts the most marginalized beneficiary communities. So this includes people who don't speak English as their primary language, beneficiaries who have disabilities, and communities of color more broadly, which exacerbates existing disparities. Next slide, please. So we did hear what works from dually eligible people, and we think we have some really important lessons learned in terms of communication that we can apply in a variety of contexts. So first of all, just explaining why options counseling is important. It's common for folks to reach out for help when they have a crisis or an interruption in care. But we got the advice that it's important to frame this in terms of an annual checkup or reviewing your options to make sure you're getting everything you can. So just when we're reaching out to dually eligible people, partnering with dually eligible people, explaining why this process is important is not something that always happens. Just about everyone looking at health insurance options, there needs to be a clear explanation of how a particular choice reduces hassle. Switching between a plan is a risk for a lot of beneficiaries. So explaining how that switch will make their lives easier, reduce hassle, reduce barriers to them getting the care they need is important to make very clear. And then, as we discussed before, beneficiaries aren't often equipped with the information they need to discern between plans. So it's really difficult, especially when there's a huge variety of plan options available, to narrow things down and figure out how exactly to make a choice between them. So making sure there's resources that are beneficiary facing to help them figure out a sort of checklist, what is or is not in a plan. And then finally, I think this is an important lesson across the board, is explaining integrated care options in terms of their impact on dually eligible people themselves. For a lot of folks, there's not a need to understand how this all works on the back end. They need assurance that their plan choices are not going to negatively impact their health or their finances. And it's important to talk about these options through that lens, because that, at the end of the day, is what matters most. All right, now I'm going to pass it to Adam, who is going to share about the policy pathways to implement all these key findings.
Hello, everyone. Thank you so much for having me to talk about this important work. The research that we're going to discuss in these next few slides is focused on how might the federal government implement a resource hub, giving existing resources and legal authority. And it was very important for us to delve into this to see how what was learned in these listening sessions could actually be implemented. Why don't we move to the next slide? We looked in this research at administrative pathways, that is using existing executive power that rests in HHS and particularly at CMS. It is always possible that Congress could pass a law and appropriate funds, but we were looking for mechanisms that could be implemented absent congressional action, given the potential difficulties for achieving this type of result on the Hill. As with any federal initiative, there are two main things that we look for when we see if there's existing federal authority to implement something. One, is there legal authorization in the statutes that would allow CMS to take action? And two, are there funds appropriated that CMS could use for that purpose? And we examined and found three potential avenues, which we're going to discuss in the next slides. That's a Center for Medicaid and Medicare and Medicaid Innovation model test, CMMI model test. Two, simply using CMS Program Management Authority and the Program Management Account. And three, running this through the Medicaid program and having states access Medicaid matching funds. Let's move to the next slide, please. Many of you are probably familiar with CMMI. They are charged with testing innovative payment and service delivery models under Medicare, Medicaid, and CHIP. One avenue that we researched and we think could be viable is that CMMI, either on its own or in cooperation with the Duals office, which we'll discuss later, run and operate a resource hub as its own form of a model test. Either that, or it could be operated as an activity in support of other model tests. This may seem a bit distinct, but there is precedent for CMMI running these kinds of resource hubs under the form of a model test. For example, the Healthcare Payment Learning and Action Network Collaborative is structured as a test, and it is essentially a federal resource hub for transforming value-based care. The legal authority being there, this is also a prime source of funding. CMMI is appropriated $10 billion every 10 years, which does not expire. For its activities, that fund is chronically underused. Some disadvantages with this approach, however, it would have to be constructed as a test. That means that it would need to be evaluated. CMMI might want controls in the form of beneficiaries who were not exposed to the intervention of an enrollment hub, and that could mean that there are perhaps states where there was no enrollment hub funded. And tests are typically time limited, something from 3 years to 5 years. So the hub, if stood up under as a test, is not necessarily made durable. Let's move on to the next slide, please. The second source we looked at would be CMS's Program Management Authority and Account. That is CMS's general authority to administer the Medicare and Medicaid programs, has legal authority within it to do many different things that could be characterized as supporting this type of enrollment hub. For example, CMS is required to inform enrollees about Medicare Advantage and their enrollment options. There is also the Federal Coordinated Healthcare Office, that's the Duals office, that is focused on Medicare, Medicaid eligibles, and one of its statutory goals is to take steps to increase Duals' understanding of coverage. So it does fit squarely within the authority for CMS to operate the Medicare and Medicaid programs. There is a CMS operating account. It is funded with $3.6 billion. However, that account is chronically underfunded. That is all the money that CMS is given to operate the Medicare and Medicaid programs and all its other responsibilities in a given year. And it may well be that those funds are simply not enough to accommodate to accommodate enrollment hub under existing appropriations. We also considered one possibility that CMS could raise existing funds through levying enrollment-related user fees on Medicare Advantage plans. There is already a levy that's made on MA plans for this purpose, and that levy could be increased. Although there is the disadvantage that if that levy were to be the means taken, plans could oppose the user fee and thereby endanger the enactment of this hub. Finally, the third option we looked at, and let's move to the next slide, is running this through the Medicaid program. And under this construct, the Medicaid, the enrollment hub would not be a federal initiative, but could be a state initiative, and individual states could stand up their own hubs as part of their Medicaid programs. This would be under authority given in the Medicaid program, and in fact, the obligation for states to make plain language information available about benefits and enrollment. And in so doing, states would become eligible for federal matching funds. These would typically be paid at the matching rate for administrative expenses, which is 50%. The downside of this being that individual states would have to stand up their own programs, so it would not necessarily give a nationally a program that is nationally in scope. And states have to find the funds to fund half of the program out of their own scarce local funds in order to be eligible for the matching funds. So those were the three main options that we reviewed. With that, I would like to pass it now over to Brandy, who is going to talk a little bit about the enrollment assister listening sessions.
Thank you, Adam. I'd like to provide a little bit more context to some of the key findings that Sienna highlighted a little bit earlier. We, NCOA and the Community Catalyst, hosted a number of listening sessions with enrollment assisters, many of whom represent the sort of Medicare counseling world through the state health insurance assistance programs. We also did one listening session with dual beneficiaries themselves, and all of these individuals represented a range of state environments. So some of them resided in states where the state has participated in the Duals Demonstration Project, or the Financial Alignment Initiative that's supported by CMS, and therefore has fully integrated care models available. Others represented states where the Medicare Advantage DSNP, the Dual Special Needs Plan, was essentially the only integrated care model. So, coming from a variety of perspectives. And if we go to the next slide. So we asked the enrollment assisters a number of key questions. We really wanted to get a sense of what the current ecosystem in their state is regarding integrated care for duals, and sort of how do people find information? How do the different agencies sort of work together in terms of, making referrals to one another? And we also wanted to know what kind of resources that people who are dually eligible for Medicare and Medicaid have access to within the state, as well as what kind of resources the enrollment assisters have access to, and where are their gaps. We wanted to get an understanding of which parts of the enrollment process work well and which do not, and how much information and training is available to enrollment assisters as they guide folks through navigating their decisions around the type of care that they want. And then finally, we asked them for suggestions for improvements in what would help them improve their navigation role in supporting duals. So if we go to the next slide, I love this quote because this sentiment was echoed throughout the listening sessions, not only from the enrollment assisters, but also from duals themselves. And one of them said, there are never any general questions about integrated care options. Everything is personal. And I think this really gets to the heart of the challenge that enrollment assisters and duals face. So many of the communications materials around integrated care plans and options are somewhat generic. They're meant to be a kind of one-size-fits-all across multiple state environments. And everyone that we spoke to really felt like their role was to go deeper and to really have to work with individuals and their personal experience and provide that very one-on-one assistance to understand what was important to them in their care, and helping to match the model of care to what they needed. If we go to the next slide. Just wanted to dive a little bit deeper into some of the key findings we found with the enrollment assisters. One of the things that we asked them is, how do these individuals find you? And in the majority of cases, The first stop for many beneficiaries was their Medicaid caseworker. So a person perhaps was already on Medicaid, they're suddenly becoming eligible for Medicare due to age or disability. And then that Medicaid caseworker refers them over to the SHIP program for that sort of Medicare counseling. One thing we heard from, many of the SHIP counselors is they felt like they had very little knowledge of Medicaid. They felt like, our lane is Medicare. We know a lot about Medicare. And there are a handful of SHIP staff and volunteers that are well-versed in both programs, but it really does take years of working as an assister to feel like you're comfortable enough to understand both programs. And that's why it's extremely important for those relationships between the Medicaid office and then the SHIP Medicare counseling office to be in place so that they can kind of help each other co-navigate on behalf of the beneficiary. There were lots of confusion regarding the different plan types, the options. A lot of enrollment assisters said that their clients felt tremendous anxiety about making the right choice and what that meant for their care. And this is impeded by so many of those structural barriers that exist related to just healthcare in general, not even looking specifically at the duals population. So, digital access to be able to, find more information about provider networks, to navigate Medicare Plan Finder. Of course, there are those language barriers that Sienna noted before. And then several of our enrollment assisters did sort of mention the fact that they encounter a number of individuals with some mental health challenges among this population, and being able to assist them with some of their very real challenges, not only with sort of understanding the options, but also with finding information on providers for their mental health services. Sisters struggle with, sorting the many, many plans that are out there. One of the enrollment assisters we spoke to said, there are, 30 some DSNPs in their particular county alone in their state. And how am I supposed to understand a nuanced difference between what those plans offer? Especially, how can I compare provider networks and some of those supplemental benefits? Many of the enrollment assisters who are working with Medicare are using the CMS Medicare Plan Finder tool, which allows you to see a very, very basic checklist of some of those supplemental benefits, like there's dental benefits and there's vision care. But in order to get a deeper understanding of the extent of those programs, you do have to jump over and off of the tool and learn more by going onto the plan website. And enrollment assisters simply don't have the time to do that. They did, however, say that there were already a number of resources out there. They said, the resources that explain what integrated care is are plentiful, but they're scattered. There's some from CMS, there's some from NCOA, there's some from ACL. And what's missing is some really state-specific information. Most of the resources out there are, again, kind of written for a more generic audience and kind of trying to do a one-size-fits-all approach. Several enrollment assisters said, we deal with people who have just sort of general health literacy skills. And so the more we could have visual aids to help people to inform their choices, the better. They also really said, we'd love to have better access to people in key administering agencies, particularly the state Medicaid agency, for those that were not on the Medicaid side. Another key tip that came out of the enrollment assister listening sessions was that outreach and communication to consumers needs to happen on a much greater scale than what just the enrollment assisters do. They're very much small, embedded in their communities, working with limited budgets, and they'd love to see CMS or somebody else put more effort into kind of doing a more sort of national campaign. One of the things they said were tools like the Medicare and You Handbook are just not really useful for this population. I mean, it's just a very basic Medicare coverage. It doesn't do a deep dive into sort of the experience of being a dual and choosing to coordinate your care. And then what I thought was really interesting was a number of enrollment assisters talked about, the way mailings are not either unreadable, they're unreadable for beneficiaries, or they're simply not useful. And one of the assisters had a really tremendous recommendation and said, there's no such thing as a standalone letter. We should really think about, can we get some of these administering agencies to send the same letter to a network of people who have contact with the beneficiary, a caregiver, a family member, their provider network. Because if we rely on a single letter to do all this work to inform them about, their options or what they need to do, often that just, gets put away. It's not understandable. If we could reinforce the message across the kind of community that touches the beneficiary, we might go farther in helping that individual. If we go to the next slide. And so, we asked similar questions of duals beneficiaries themselves, and, the same sort of problems that the enrollment assisters identified or thought that was the experience of beneficiaries was echoed by the beneficiaries. So many of them said that they had to juggle a lot of different considerations and needs when they were looking at their options. Are my providers in network? If I have a need for home health services, if I have specialized durable medical equipment, if I need wraparound services, what plans are available to me? Am I able to get some of those through my preferred provider networks or clinics or facilities? It was easier for those who had that initial one-on-one navigation support. So a number of the duals in our listening session said, oh yeah, it was fine when I enrolled in integrated care. But when we probed a little bit deeper, many of them already had a social worker, a service coordinator, a care manager who really, sat down with them in a personalized manner and provided information and helped them to sort of navigate through the system. And so, part of the findings of this report is just the need to kind of bolster that one-on-one navigation support. We also heard that paperwork was a huge burden and a barrier, not surprising when people have to, produce application information, income information, that sort of thing. And then the duals themselves help to identify other sort of resource needs. One was, just can we get just like a checklist, a simple checklist that we can use to, make sure that our providers are covered, to understand the coverage that's available, kind of similar to what the enrollment assisters said about provider networks and supplemental benefits, but in a much more consumer-friendly language. One of our duals beneficiaries who participated was talking about just having to accept an unwelcome or an inferior provider because that was what was in network, and they talked about the challenge that gave them. And then finally, guidance for how to read those notices. A lot of people said, I just take it to my care manager, I take it to my service coordinator, but some more kind of plain language information and tips for how to, when you open that letter, what does it mean? Who do you go to, and how to read that information? And so I think that if you'll go on, I'm turning it back over to Sienna for some recommendations.
Great, thank you so much, Brandy. I'm now just gonna briefly talk about some based off of all that we learned, what we would recommend moving forward. Next slide, please. So this is not an exhaustive list of our recommendations. In the report, we have some more, but these are some of our big priorities. And some of these are broader, more long-term, but a lot of these we can be doing now, particularly in terms of what Brandy talked about in terms of accessibility of enrollment materials, and just information about things like provider networks and medication coverage. Those are pretty actionable. So in addition, of course, based off of what we heard, we do feel like a resource hub is a viable option. We heard a lot of enthusiasm for the idea, an appetite and a need. And important to emphasize that we heard this from a variety of stakeholders. But of course, it's all in the details. And we've gotten a lot of great recommendations about a design that, if implemented, would address many of the enrollment related challenges we hear about constantly. And it would build a stronger infrastructure for enrollment assisters, for seeking technical assistance, getting access to data, reaching out to other assisters, and just really creating a more streamlined system for folks to get information about this stuff. There's a lot of federal developments we can chat about a little more in the Q&A, but we feel like this really responds to what we've heard in the field. And a resource hub would be a great way to put all that we've learned about and all the issues we frequently hear about into action, and build upon that to make the enrollment experience more consistent, more accessible, and making sure that folks doing this work on the ground have the resources and support they need to continue it. I'll leave it there with recommendations and pass it back to Lena.
Great. Thank you, Sienna, and thank you, Adam and Brandy, for your presentations and sharing out all that we've learned in the past couple of years through this project. So let's focus now, we can have a discussion if folks have questions. We also welcome your comments and reactions to what you just heard in the Q&A or using the chat function. So please definitely put in your questions and comments. But why don't I, sort of ask one question for Sienna, and then others are, Brandy, Adam, please jump in. But Sienna, can you talk a little bit about, Adam touched on the pathways via CMS, CMMI. Can you talk about some of the policy pathways via legislation?
Yeah, to start to answer that question, there's a lot of enthusiasm at the legislative level right now to specifically address issues impacting Medicare, Medicaid enrollees. So it's an exciting time on the Hill. A lot of representatives are recognizing the importance of this issue and are becoming more informed about it, and are proposing specific solutions. So there's a bipartisan working group of senators who put out a request for information this past winter, which we and many other groups responded to, and all of that feedback went into a discussion draft of potential solutions to a lot of the issues we identified today. In addition to that, there's a lot of legislation that was introduced in the previous Congress that we expect to be reintroduced in this Congress. Variety of approaches. To name a few, there is the Advancing Integration in Medicare and Medicaid Act. So this requires state Medicaid programs to develop strategies for integrating and coordinating Medicare, Medicaid coverage for folks who are dually eligible for both. This includes enrollments, quality measures, and access to care. There's the Comprehensive Care for Dually Eligible Individuals Act, which creates a new program that states can choose to take up. And this allows them to better integrate the two programs and allow dually eligible people to select the type of coordinated care that works for them. There is the Supporting Care for Dual Eligibles Act, which creates a dual eligible quality care fund that provides grants to state Medicaid programs to improve their capacity to work on integrated care. And there's the Coordinating Dual Eligible Recommendation Act, which requires MedPAC and MACPAC to conduct a review and analysis of Medicare and Medicaid policy with respect to program spending and utilization. So a lot of different approaches. We have more details about this in the report, but there's a lot of legislative avenues to approach this. Obviously, there's a lot of different pieces that go into this, so it will probably not be just one behemoth piece of legislation that fully addresses the issues we've identified, but there's a lot of potential solutions on the table, and we expect more to be added.
Thanks, Sienna. And we just saw a comment come in through the chat function. A central hub could make sense, but for more impacted individuals, they really need to know about their options. What options do they have specifically? General information isn't all that helpful. Absolutely. And I think just going back to what you said, Brandy, and I think the quote, right? This is personal. People really need to know what their choices are, what their options are, and what makes most sense, and how they can live a quality life based on their preferences. I'll pause there. I don't know if Sienna or Brandon, Adam, if you have any reactions either to the comment or anything that Sienna said.
Yeah, definitely. I think the goal there with the central hub is not to just have basic information, but to also have tools there and state-specific information, so folks can get answers to their specific questions, knowing that like our enrollment assisters very clearly identified, there's not a one-size-fits-all tool. So if we just give general answers to general questions, yeah, that doesn't really help anyone. What we heard though was it's a bit of a wild goose chase tracking down answers to all these specific questions. I know there's some quotes in there from enrollment sisters about spending a lot of time on hold, having to jump from person to person to get an answer to a particular question. So we're hoping that by consolidating all of this information, we can streamline that process and ensure, with the limited time and capacity they have, they can answer those, tailor their assistance to what individuals need.
Great. I think I'd like, to pose a question to the group here about equity. Some of the ways that you might recommend centering equity based on what you've heard and what you've researched for this project.
I can go first, or do you want to go, Brandy?
Sure. I mean, just to start, I think we know language access continues to be a significant issue, language and digital access. And so having a lot of the notices and the forms available in more languages, simplifying the language that is contained in those, having a modality too for individuals who may not speak English as a first language to be able to talk to somebody in person, because a lot of times it's not simply about translation, it's about literacy as well. I also think that, where it's possible to enable enrollment assisters to have just more training and experience in kind of troubleshooting some complex cases to be better able to help their clients. I did see that sort of comment in the chat about SHIP counselors seeming to have bias against managed care for Medicare, and that's something I've seen elsewhere in the world. I mean, obviously SHIP counselors are supposed to be unbiased and objective. But I think part of the challenge is that going back to that lack of nuance in being able to sort of compare plans, and if more information was available about the specifics of those plans, then I think counselors would feel a little bit more comfortable being able to assist their clients and comparing and seeing whether that was right for them.
Yeah, I would say, I know it sounds simple, but we've seen in practice it's more complex. It's putting dually eligible people at the center. And what that looks like in practice is not just transactional, not just consulting dually eligible people on the back end, not asking people their opinions about an enrollment notice after it's already gone out, not having kind of built-in accountability measures and just feedback measures for things like, do these materials make sense to you? Would you find these materials useful? What kind of information would you like? When those questions don't get asked, we really just see dually eligible people themselves as this end user, this kind of passive entity, and they're not really at the center of all of this work, and they should be. So what does it look like? What should we be working towards? It looks like building bidirectional, long-term, trusting relationships with individuals, advocates, and communities that represent dually eligible people. It's a long-term investment. It takes intentionality, but those folks are there. They are engaged in this. They have great input and feedback and want to design the enrollment process to make it better for both themselves and their peers. So I think it's a matter of tapping into that and building those relationships long-term to make sure there is that bi-directional relationship that just overall makes the products that are coming out, the tools we're using to navigate these things better.
Thanks, Sienna. I know we only have a couple of minutes left, and there's some conversation happening in the chat right now. One of the questions around AI. I think it's a good question. It could work. I know it's coming up in a lot of conversations that I'm a part of. Probably need so much more learning on that end and the type of data that's fed into it to know what kind of information it's giving to beneficiaries or others who may be using it for options. But I think that's a great question. Other comments focused on, a national hub could potentially be a good idea, but would have to be customized, which we absolutely agree. I think a national hub in a format online or a hotline alone is just not sufficient. We think that it has to be customized by the state, and it also needs this robust community infrastructure around it and on the ground to everything that Brandy and Adam and Sienna touched on. I think in combination it could work, but distinctively and alone it would not. It certainly would not work for this population.
I saw the question, the comment in there about informing physicians and their staff. We heard that a lot, that people come to their primary care provider and say, "What's this? I got this letter." And if their PCP isn't familiar with it, they're not going to advise they enroll in it because they don't know the ins and outs of it. So they're not going to be comfortable making a recommendation. So definitely outreach to the folks advising dual eligibles, like what Brandy talked about, making sure they know what all these options are, and these options change a lot. So making sure they have access to information so they can just provide feedback. At the end of the day, it's the dually eligible person's choice. But of course, they can and they do reach out to other folks to help advise.
Thank you, Sienna. So I know we have just a couple of minutes left. We really want to thank you, Sienna, thank you, Brandy, Adam, for participating in the webinar and for all the work that you put into for this project. For our audience, I put the link into the report at the chat, but we've sent it around in a larger email blast. We will follow up with everyone who signed up for the webinar and circulate our report, the recording, the slides, as well as we have an amazing video of a beneficiary as well that we will be releasing today. So we will be sharing all of that with you afterwards. Please share it with your networks, and we really appreciate everyone joining today and participating in the conversation that we had over chat. So thank you all and take care.